Welcome to GNN10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kenar Jhaveri of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koyal Jain from the University of North Carolina, Chapel Hill.
Welcome to GNN10 with Koyal Jain and myself. We have a special episode today that Koyal is going to introduce. We're going to call it the Ped GNN10. It's going to really take us to the pediatric glomerular disease world.
Yes, we're excited about this because we've really not talked about pediatric patients as much, but they're really important. Kids are so close to my heart. And then we have these amazing pediatric nephrologists who've joined us. We have Jun Oh and Louise Oni, who will be talking about some updates in pediatric glomerular diseases. So why don't you both tell us about yourself and how did you get involved in glomerular diseases?
Thanks for the warm welcome and for putting the spotlight on the children, which is a real privilege, and we're very grateful to be here. I'm Louise Oni. I'm a professor of pediatric nephrology. I'm working in Great Ormond Street at Children's Hospital in London, and I support one of the large glomerular disease clinics there and also the nephrotic syndrome clinic for children, and have a research interest in glomerular diseases and work very closely with our adult colleagues to look at glomerulonephritis across the ages. My interest was first from doing a PhD in lupus nephritis and working very closely with our pediatric rheumatology colleagues, and have continued to have that interest over the last couple of decades, and now chair the ESPN Glomerular Disease Working Group, where we have a really active group of members all interested in trying to drive forward the progression for children with inflammatory kidney diseases.
And I'm Jun Oh. I'm a professor of pediatrics from the University of Hamburg in Germany. And thank you for inviting us and give pediatricians the platform to talk about our side of this glomerular diseases and the involvement and the changes we're currently facing, which is amazing for us taking care of so many patients with rare diseases and ultra-rare diseases. My interest in proteinuria started over 20 years ago when I started working at Peter Mondel's lab, starting on the first baby steps of the podocytes. And now I'm more involving in clinical trials rather than looking what the individual podocytes are doing. It's just great to see that what we did there and entering into the development of drugs and now ending with target drugs and clinical trials, which is an amazing journey. And particularly for us as pediatricians, this is just a unique time, I think.
Welcome, both of you. We're so excited to have you.
All right, so we'll get started. Just to clarify, Louis was mentioning ESPN. That's not where we think it is. It's actually European Society of Pediatric Nephrology, just in case people are thinking Forbes. So let's start with C3G, which is a pretty happening topic in the adult world. 2 new trials that just splashed in ASN. What do you think, Louis or Jun Ho, about the role of any of these drugs in C3G in pediatric patients?
Yeah, a really exciting time for us. I think one of the advantages, and also perhaps one of the disadvantages with pediatric nephrology, is that there is a lag to the drugs reaching the children. That has its advantages in that we can see what's coming and what opportunities lie there for our patients, but also we see that then there might be a delay in them reaching the actual children who might have disease. And so what we see is a really exciting time when the trials are just coming to the children. You've got the results in the adults, we can see the fantastic outcomes. We have no reason to believe that the children wouldn't respond in anything differently to what the adults have responded. So it's a really exciting space to open up much more targeted treatments for C3 glomerulonephropathy and also provide children the opportunity to take part in evidence generation. So for us, we're on the edge of that energy and that excitement that you've got the actual figures and the results. We're just at the beginning of that wave of excitement and the next generation of medication. So really important time for our specialty and for our patients. And what we hope to do is really deliver on those trials so that the children get the evidence they deserve as well.
There's one thing which might be different from our adult colleagues. It is a rare disease, and in particular in children, we have smaller centers. It is so important for us that we connect to each other and work together. So that's why this international collaboration, coming together and sharing data and sharing patients, is really important for us, because we only have few patients in individual centers. To exchange experience and also to learn from each other, there is this need for coming together and connecting.
And just for our listeners, the 2 drugs we're talking about is iptacopan and pegcetacoplan. I can never say that one. But the iptacopan trial did not include any pediatric patients, to my knowledge. The pegcetacoplan had kids above the age of 12. So not the very little kids, but at least above 12. That should help the pediatric colleagues. The trial's not published yet, but I'm assuming pretty soon data will be very good for our kids to get those drugs as first-line therapy, and not just MMF and steroids.
Sorry, to take a step back though, you're both coming from two different countries. What are you right now using, and what are people using worldwide for pediatric patients for C3G?
I'm afraid that's where the lag comes into this. And on average, what we've seen from previous historical studies is that there's a 13-year gap between the drugs reaching the adults to reaching the children. So unfortunately, in clinical practice, we're still using steroids, MMS, very broad spectrum immunosuppression. So we don't have the access to these drugs. We're excited by the trials coming through, but even in the luxury of the centres that we work in, we don't have access to these drugs for our clinical practice. We're still using very broad spectrum medications, and children really don't like the side effects that are experienced, particularly from steroids. I think in terms of what's actually changed our clinical practice right now, nothing's changed for some time. What we can see, and particularly as clinical academics, is that's on the horizon, and that's exciting.
Also, for security reasons, right? You have to convince parents, and also you have to be convinced by yourself as a treating physicians that it's safe to give this drug to a child for a long time. So far, these are also new drugs for our adult world, but you can talk to your patients, they decide for themselves. In our hands, it's a little bit different, right? We have to be really sure that there are no long-term side effects. So what we're doing now is following what you're doing, following your results, and trying to understand how we can use this. Some of the drugs will work the same way, better, but some of the drugs will maybe have a less strong effect. Let's say the immune system in a child is different from an adult. It's maturing, it's developing. So there might be some difference. So we're talking about kidneys at a young age in comparison to kidney at an older age, which means the structure, the function might be different, right? So the impact can be different. So we're following and we have to learn. But what we are trying to do is to shorten this delay and try to be as fast as we can to prove that these drugs are actually also safe for the children.
I wanted to shift gears a little bit. The other big news splash, at least in the adult world, has been the use of SGLT2 inhibitors for almost all proteinuric diseases, from glomerular diseases to diabetic kidney disease to FSGS. Do you use SGLT2 inhibitors?
It might take more than 10 minutes to talk through the SGLT2 inhibitors. What happens in adult trials is there will be a pediatric investigation plan linked to it that our regulators will impose needs to be done so that the children can access some of the medications, or at least the trials. Unfortunately, sometimes waivers are placed to say that this study can't be done or isn't safe, or there is some reason why the regulators feel that the study shouldn't be done. And so for most of the SGLT2 inhibitors, our industry colleagues got waivers that meant that the trials wouldn't proceed with children. So that led to a really big global community coming together to try and actually work with regulators, work with industry, work with patients. And together we've now put a really fantastic trial protocol that's going to open shortly to evaluate SGLT2 inhibitors in children with all forms of CKD, no matter what the etiology is. It took a very big global effort to bring that together, but I actually think it united our community and also brought in the expertise from our adult colleagues, which we really do depend on in pediatrics, because we are a small community and actually the drugs often do reach the adults quite rightly first. And so we have to learn from the expertise that exists in adult nephrology. I think there was a lot that was learned from that situation. What's happened in clinical practice is that some teenagers will be prescribed them off-label because we know that they're probably going to work in the same way as an adult, but the younger children don't have access to them at the minute. Hopefully those trials will get delivered quickly and then we'll have the evidence again that children deserve and we can start to use them more freely.
We have to mention your role, Louise. It's thanks to your hard work and the support and partner with institutions like NephCure, this was moving forward. So me as a pediatrician, I have to thank you. Without your activities and your passion to perform this clinical trial, we wouldn't be there at this point. So we're really looking forward to learn. As a pediatrician, when we just think about the impact for the adult population, if you theoretically calculate what this could mean for a child at the age of 1 year and starting to have a glomerular diseases, what this means maybe at the end of his lifetime, this is just wonderful.
It's really hard to see children spending years on dialysis. You can't buy back that childhood. So the thought of any treatment that's able to buy children any amount of time to preserve their childhood and push that kidney failure endpoint into adulthood is a real exciting time for us. And we see that with the treatments coming through for glomerular diseases. We see that with the SGLT2 inhibitors in adults. And so as our community, we feel that for the children, that there is hope that some of them might get some childhood back, because there are too many childhoods lost at the minute to kidney failure and sitting on dialysis, and it's not acceptable.
Thank you so much for your work. It sounds like you've put in a lot of effort into this. What age group is this new clinical trial, the global clinical trial, in?
It's a 2 to 17-year-olds. Hopefully we can capture everybody and make sure that they're safe in the younger population. And obviously the best way to evaluate the safety of a drug is within a clinical trial setting. So we will hopefully get the answers that gave everybody the nervousness at the beginning to hold off. Hopefully it'll be a landmark trial for our community as well, which would be great.
So I feel like the theme for this has been that we need more clinical trials and more involvement in the pediatric population, which brings me to two other diseases where we have so many therapies in the adult population that have suddenly come out in the past few years, IgA nephropathy and FSGS. But what's been happening in the pediatric population?
We have this current situation that we are already participating in some of the trials. The numbers are still so much lower in comparison to the adult patient population, but still there's a growing clinical trials finally for us. We have multiple trials coming to our centers, but it's a lot, and the patient population is not so large. So we have to make sure that we can complete all these clinical trials, and that's what we're trying to do, to complete the trials, to get finally this information whether the drug is safe and successful.
For IgA nephropathy, at this point, for pediatric patients mainly, supportive care and steroids.
Yeah, we're seeing the trials like sparsentan and some of the early trials that came through. We're starting to get conversations of advisory boards and starting to help with the design. We know the treatments are coming. The challenge is going to be making sure we can deliver and capture these rare disease patients within trial networks. And that's really potentially going to be a huge opportunity for our specialty to start to come together globally and develop these networks, develop registries where we have patients captured, and also learn from what potentially has happened where you now have a whole plethora of treatments and no kind of way to biologically categorize patients. And actually we might be able to collect biosamples at the same time that would allow us to learn whilst we do. There is some advantage to that lag that we can actually see where we might be able to add on additional information that could help us with prescribing in the future. It's an exciting time. I think it's also a nervous time as to whether we can deliver all of these trials, because if we can't, and many trials don't manage to recruit, then the children won't get the licensing that they deserve. It is important that we try and get the right evidence that allows them to get the proper tag that means that these treatments are safe and effective for them. And unfortunately, about a third of clinical trials will be terminated due to poor recruitment. So we have a lot on our plate. We also are a small community, and we've started in partnership with colleagues at ISGD, trying to train the next generation of colleagues to be principal investigators, to think about clinical trials and start to get that energy.
And another initiative we started within the ISGD group is actually to build a subgroup of pediatricians, to use this platform to bring these people from all over the world together and to connect and to make sure that we find these patients in various centers and find a way how we can include them into clinical trials. So we just started the ESPN meeting in Athens to find the right persons to come together and work on this, because I think this is now a unique time, but we are complaining all the time about these missing trials, and now they're there. So now we have to show that we are capable of completing these trials. So there's a pressure also on our side as physicians to deliver finally. And I think we have to use this, let's say 10, 15 years where a lot of changes will happen in this field. And if we don't deliver, the pharma may move to a different field. And so that's why I think this connection is, for, as an example, this pediatric subgroup in ISGD is developing. And I think that if people are interested, they just can reach out and participate in this, which is currently Louise and I trying to set up together with the leadership team of ISGD.
I will be very honest. When we were coming up with some of these questions for you all, I was hoping that there'll be some like, oh, these are these great trials and these are the results and this is the new drug. But it seems like we still have so much room for improvement in terms of the number of clinical trials needed and the recruitment needed and the results needed that were not there. I feel like I was a little bit naive. I knew that clinical trials were needed in the pediatric population, but not to this degree.
Since you both are on, I have more questions. We use a lot of rituximab and obinutuzumab. in our FSGS, lupus nephritis patients, and given your experience, what is the role of such drugs in pediatric patients? Are they commonly used?
Yeah.
Rituximab, we gain more and more experience, and this is commonly used over and over. It started to catch up. And again, we were discussing a lot in our pediatric cohorts about long-term use of rituximab. So that's what we are always discussing at this point. These drugs are so new, but still, we are still lacking this long-term information, so what's happening, but it's growing. Rituximab.
Yeah. We don't understand, like, we have children now who maybe have had B-cell depletion for 10 years of childhood, and what does that mean to them? Is there a reason why they actually get those viruses, get those infectious insults, and the B-cells are exposed to that, and actually what we're doing is depleting them? So what we don't know is whether we're setting them up to have challenges in adulthood, and that's where our very long-term registries are going to be beneficial. So there's a lot unknown, but we do use them widely. We have to use them, otherwise the children will be quite sick. We use them particularly in lupus, particularly nephrotic syndrome. But rituximab is there when we need it for more severe, rapidly progressive disease as well, because one of the subtle differences compared to adults is that we strive for complete remission, and we strive to treat them with immunosuppression, even if we feel that they may have irreversible histological features. So we really do try to fight for that time off dialysis as much as possible. And often you'll see that we use lots of immunosuppression if they're really quite ill. And that's often because we do see reversibility, and a couple of months off dialysis is a benefit to a child. I think one of the other missed opportunities as well in pediatric glomerular diseases is that the children are a really clean phenotype. They've not got the comorbidities, they've not got diabetes, they've not got hypertension. So for science, they're a really clean group of patients where they have a very severe inflammatory disease and they were previously well. So trying to capture that in cohorts and learn from it, I think, is a huge unmet need. And we saw that really nicely when the antinephrin studies were really inclusive of all the ages. And the children really dominated that positive antibody group, actually. So I don't think we've done that at scale properly yet. And I think that's an unmet need where we should be looking at these children, looking at their immunology and trying to capture it, because often we see very acute, severe disease, even like IgA nephropathy, FSGS, and the children can progress quite rapidly to chronic kidney disease with significant proteinuria.
We have this genetic information in many of our patients. That's also a big advantage because we are screening so much more. So we have a lot of genetic information in all these patients. I think what's going to happen is 10 years from now, we will have genetic newborn screening all over, which means that we have a lot of genetic testing on all children. And now we have to understand which of these mutations have an impact on the long-term outcome of these children. And then because of the drugs we're going to have, we have to decide whether we can use these expensive drugs, even though we don't know whether this drug will have a phenotype. So 10 years from now, rather than treating these patients and they will transition to you, it's rather the prevention, because we will have a lot of information from the first day of life. So I think that's why I think we as a pediatrician and you as adult physicians, we have to join and think about the next 10 or 15 years, because everyone will run with some diagnosis. And there will be a lot of people nervous because they have to make decisions. And I think this is something now, the next 10, 15 years, are really important to be prepared for this situation.
Jun, based on what you said, and this came up at ASN as well, at least in US, you depend so much on life insurance and those policies, and they take into account if you've had a test which is abnormal, right? Like you can be denied sometimes, and that sort of carries forward with you. And so when somebody has, let's say, nephrotic syndrome and you're sending a genetic test that's different than somebody who's newborn, doesn't have kidney disease or any disease, and now getting genetic test, how is it there?
Yes, it's going to be a huge impact. I think the information will be available at a certain point because the techniques is there. It's cheaper to test everything, and then afterwards pick the candidates and give this information to the patients, but also your individual decision, what you're going to study, what you're going to do, because you're going to be afraid. And the health insurer are going to use this, or your future employee in companies, where you're going to work. So I think that this is something we have to deal with. I think that's what I'm trying to point out, is that we have to use the next 15 years to be prepared for this and to secure that these patients or all the healthy populations are safe, even though they have this genetic information available.
I just wanted to wrap up to ask Louise a question. She's done a lot of work in anti-GBM. Just give us maybe a little bit of an update in treatment in anti-GBM in pediatrics. Is there any changes or anything that we can look forward to that might change the course of the disease?
I think this is where you then get into a very grey area, because actually I'm part of an international recommendation group at the minute, and they've just looked at all the literature, and there are 5 children in a case report for pediatric evidence for anti-GBM. It's ultra rare. And actually, I suspect we could do better in terms of evidence. And it's really inspired me to look at how we need to just even get retrospective cohort data out there, because there's very little out there published. Most centres will see 1 a decade, 1 every 5 years or something. We might see in Great Ormond Street, London, maybe 1 a year. What we tend to see, though, is that the patients will present very acutely, very severely, and we would use lots of immunosuppression. So usually plasma exchange, usually steroids, usually cyclophosphamide, rituximab, anything that would try and reverse that element of their disease. And we do see damage in those children where the kidneys are irreversibly damaged due to the speed of the disease. I think in terms of evidence generation, it's a very difficult space. And I know that even the trials for things like in imlifidase have not been able to proceed due to the numbers being too difficult to recruit to. So I think until we get this infrastructure and networks and patients captured in registries that allow us to then have this web, this global web that can connect, and we're able to then have a more fluid way of finding children, I think it will still be a very difficult space for generating evidence in these ultra rare conditions. What would be nice is a way to capture the use of the kind of off-label acute or compassionate use of drugs. You're using drugs where there isn't evidence, but I think there is still a space that we could learn from the use of them in real life clinical practice. So I think anti-GBM, we will throw anything at them, broad spectrum treatment. Generally, that's where plasma exchange still does have a role. But I think in terms of evidence and literature, it's very patchy, and it is really down to just single case series, case reports, and nothing stronger than that.
I'm thinking more now because we don't think about vaccines that much in adults. If I had to give rituximab or immunosuppression to very high degrees in a 2-year-old, how do you adjust their whole schedule? Are we putting them at major risk in terms of antibody formation at the key time of their life when their immune system is really prime?
That's a real risk we're dealing with. And we are following the antibody concentration and measuring them, and some get revaccinated. But it's a problem depleting the B cells. Some of them are treated with antibiotics permanently at the same time. And we still have to wait for these long-term outcomes to see what's happening. But there is potential that we impact this immunological response for a long time.
We're balancing that there against the risk of kidney failure. And we know the children who have kidney failure, if they stay on dialysis, their life expectancy is actually often worse than many childhood cancers. So we're in a constant balance of what's the right thing to do. But we know that chronic kidney disease and kidney failure are actually not good in the long term in terms of cardiovascular outcomes. And these children will often die as young adults. So it's a balance, but it's also a desire to avoid that endpoint.
I have to make one comment where Kenar said we don't care about vaccines or think about vaccines in the adult population, because that is not true. We do routinely think about vaccination in the adult population, although I do agree there's a lot more vaccines in pediatric population.
Yeah.
I will also say, Kenar, we actually have a really nice collaborative relationship with our pediatric nephrologists here, and they use a lot of rituximab. They've also used some ofatumumab. Those pediatric population kids have moved on to adult population, and they've been able to get them the vaccines and have been able to work around it. It's been hard and it's been tough. Before we end, I will also say that thank you both for the amazing job and work you do. I don't think I could have worked as a pediatric nephrologist personally. Even though I love kids and even though I love nephrology, it is really hard to take care of children. And it's really hard to see them suffer. And it takes a really special person to be taking care of that population. So thank you so much for all the efforts and the work that you put in. And thank you so much for joining us on GN 10.
I just want to thank you guys. I just can't talk to parents. I don't know how you guys do it, but when those adolescent kids get transitioned, it's very challenging. Kudos to the pediatricians and pediatric nephrologists for doing that. We were used to talking to kids of older adults, and that's much easier, I think, than talking to parents of kids.
Yeah, that's sometimes a tough job, but still, we love our job. Thank you for having us here.
Yeah,
And
thanks for
thanks
giving the
us.
children a spotlight. It's much needed, and this platform allows them to be more visible and more seen. And I wouldn't change it for the world. The children bounce back as soon as they're better and get on with playing, and they don't moan. So it makes our job easy that way too. So
Next time you come to Germany, I'm going to invite you to my hospital. We can work together once. Okay?
We'll train under you, June. We'll
Yeah.
do that.
Wonderful.
This is Kenar and Koyal. We're signing off from GN10. Thank you so much for listening to us, and we'll see you the next time. Take care.
this has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found, and tweet at us at ISGD Tweets. Thank you for joining us.
Didn't want to cut Kenar, but Kenar is so deep in thought that I decided I'll just go ahead and ask you the next question. I think Kenar is like really pondering at this moment.
So wondering more about pediatrics. That's all. So
This
you
is
know,
his
we use-
thinking. This is
we
Kenar's
use-
thinking that
we
was
use
happening.
I know, she's going to tag me on that.